Hello everyone, welcome to Pediatrics and Neonatology. This video is about iron deficiency anemia in children. First, a typical scenario. A 9-month-old child who has been fed whole milk from early infancy presents with the following laboratory values. Hemoglobin 7.5 gram per deciliter, MCV 62 and RBC count 3.2. Now think of iron deficiency anemia. Now the essentials of diagnosis and typical features. These include number 1, pallor and fatigue. Number 2, poor dietary intake of iron, especially in children 6 to 24 months of age. Number 3, chronic blood loss in children aged more than 2 years. And number 4, microcytic hypochromic anemia. Now some important definitions. Iron deficiency. It is a state in which there is insufficient iron to maintain normal physiological function, such that iron stores are reduced. Iron stores include serum ferritin or bone marrow iron content. Next is iron deficiency anemia. In this, hemoglobin is more than 2 standard deviation below the normal for age and gender, and this has developed as a consequence of iron deficiency. Now some important facts about iron deficiency anemia. Normal term infants are born with sufficient iron stores to prevent iron deficiency for the first 4 months of life. Premature babies have reduced iron stores since iron is predominantly acquired in the last trimester. Now reduced iron stores are present in premature infants, low birth weight babies, neonatal anemia, perinatal blood loss, or subsequent hemorrhage. Now, breast milk is low in iron, and without iron supplementation, iron deficiency may develop in exclusively breastfed children. Next, increased consumption of bovine milk or cow's milk can result in iron deficiency anemia because this milk is low in iron content and blood loss occurs from milk protein colitis. Now the symptoms and signs of iron deficiency anemia. It may vary with the severity of the deficiency. Iron deficiency is usually asymptomatic, and iron deficiency anemia may result in pallor, fatigue, irritability, anorexia, tachycardia, flow murmurs, high output cardiac failure. In addition, iron deficiency anemia may result in pica. This is a desire to ingest non-nutritive substances. There may be phagophagia, that is, desire to ingest ice. Now, iron deficiency adversely affects long-term neurodevelopment and behavior. And in these children, increased lead absorption can cause subsequent neurotoxicity. Now, other signs and symptoms include chylosis or angular stomatitis, glossitis, chylonychia or spoon nails, esophageal web, blue sclera, or splenomegaly. Now some important laboratory findings. Decreased serum ferritin, that is less than 10 nanogram per ml. Decreased serum iron. Increased TIBC, total iron binding capacity. Microcytic hypochromic anemia. Increased RDW, that is red cell distribution width. Decreased RBC count. Absolute retic count is normal or increased. There is increased platelet count, but it may be normal or decreased in severe cases. Now the peripheral film picture, there are cigar-shaped cells, elliptocytes or variable sizes cells. Bone marrow is hypercellular with erythroid hyperplasia and decreased stainable iron. Now in this picture you can see a child with iron deficiency anemia and chylonychia of the nails, and this is the peripheral film showing hypochromic microcytic anemia. Now the differential diagnosis. Now the differential diagnosis of iron deficiency anemia. These include alpha thalassemia, beta thalassemia, and hemoglobin E disorders. Now in thalassemia there is elevated or normal RBC number. There is normal RDW and Menser index, that is MCV by RBC number, is less than 13 in thalassemia, while in iron deficiency anemia it is more than 13. Now there is normal or increased level of serum iron and ferritin in thalassemia. Now there may be normal TIBC, hemoglobin electrophoresis in beta thalassemia minor, there is elevation of hemoglobin A2. Now another differential is lead poisoning, in which there is microcytic anemia. Another differential is anemia of the chronic inflammation or infection, in which there is normocytic or microcytic anemia. Now CRP is also elevated in anemia of chronic infection. Now other differentials are mild infections, in which there is transient anemia. Now a screening test should not be obtained within 3 to 4 weeks of such infections. Now the treatment of iron deficiency anemia. If a child hemoglobin is less than 10 to 11 gram per deciliter at 12 months screening visit, then closely monitor or empirically treat with iron supplementation with a recheck of hemoglobin in 1 month. However, if a child has iron deficiency anemia, then give oral elemental iron 3 to 6 mg per kg per day in 3 divided doses, and these should be given between meals with some juice. Oral iron is less expensive, less toxic, and is fast and effective. Now, in iron deficiency anemia, parenteral administration of iron is rarely necessary. Now, in iron therapy, there is increased retic count within 3 to 5 days, and it is maximal between 5 and 7 days. Rate of hemoglobin rise is inversely related to the hemoglobin level at diagnosis. Now, resolution of the anemia occurs within 4 to 6 weeks, and treatment is continued for a few additional months to replenish the iron stores. Okay friends, thanks for watching. Please like, share, comment and subscribe to my YouTube channel for more informative health related videos.